Welcome to Where Science Meets Self-Care with Ida Fanelli. With over 30 years in beauty and wellness and a background in medical science, Ida blends clinical knowledge with holistic care. Each week, she and her guests share insights to help you achieve healthier skin, balanced energy, and empowered self-care. Now, here's your host, Ida Fanelli.
Today, I have the pleasure of speaking with Gordon O Telford, MD, FRCPC, Dermatology and Internal Medicine, FAAD, a Canadian physician with dual specialist training in dermatology and internal medicine. Dr. Telford has investigated a vitamin-based approach to sun protection grounded in cutaneous physiology. In this conversation, we will examine that work and explore where our perspectives align and where they thoughtfully differ on strategies for skin cancer prevention. If you are someone at increased risk for skin cancer, we invite you to stay with us as we explore evidence-based strategies that may help inform prevention based on this article. Non-melanoma skin cancer is a potentially preventable disease. Now we'll discuss his background and clinical experience. Dr. Telford practiced medicine for over 4 decades with a clinical focus on non-melanoma skin cancer, photoaging, and preventative dermatology, and is now retired from private practice in Nova Scotia, Canada. He completed specialist training in internal medicine and dermatology, earning fellowship in the Royal College of Physicians of Canada, FRCPC, in internal medicine in 1977 and in dermatology in 1979. He has also been a fellow of the American Academy of Dermatology, FAAD, since 1981. Throughout his career, Dr. Telford demonstrated a strong commitment to clinical research, medical education, and patient-centered prevention, alongside leadership in nonprofit and professional organizations. His work integrates insights from photobiology, cutaneous immunology, and nutritional biochemistry, emphasizing long-term skin health rather than short-term cosmetic outcomes. Beginning in the late 1970s, Dr. Telford followed high-risk patients longitudinally and explored the role of topical vitamins and antioxidants as adjuncts to conventional sun protection. His open-labeled prospective clinical experience informed a prevention model centered on immune preservation, reduction of oxidative stress, and protection beyond ultraviolet radiation alone. In addition to his clinical work, Dr. Telford served for 30 years as a medical expert and commentator on CFAX radio, where he translated complex medical topics for the public and contributed to community health education. Welcome, Dr. Telford.
Thank you very much, Ida. That's a very nice introduction.
You're welcome, and I'm so glad that you're here.
Absolutely.
Dermatology organizations describe non-melanoma skin cancer as an epidemic with over 6 million procedures annually in the U.S. Despite decades of public education and widespread sunscreen use, incidence continues to rise. From your perspective, why has prevention failed to keep pace?
What we're going to do just for a moment is we're going to go back and say, what were the basis on which people made decisions in the old days, okay? Back when I was first starting my practice. Scientifically, ultraviolet light, sunburn specifically, was a complete carcinogen. So that the development of sunscreens all occurred saying we need to prevent sunburns. Therefore, we need to block UVB. Over time, and this is where I come in too, as I watched my patients, right? These are guys who have multiple skin cancers. I see them every 2 or 3 months. They come in with a new skin cancer. And you say, you know, these sunscreens you're wearing don't seem to work. You're still getting skin cancer, okay? So that's the background. So we saw clinically that improvement in SPF protection did not translate into cancer prevention. Now we have SPFs of over 100. We have added UVA, so we broaden the spectrum of protection to include UVA, and we still see the same thing. This sunscreens are not preventing skin cancer. If you look at why, what have we done wrong? What we're failing to realize is that sunscreens are designed to block UVA and UVB, which is only 7% of the light that strikes your skin when you walk outside. The other 93%, 43% of it is visible light, so what you see. The big one is infrared, and infrared you experience as heat when you walk outside. Well, that infrared, in fact, is 50% of the sun's energy. So we've taken a little tiny narrow spectrum, focused on that, and missed the big picture. Okay? I don't mean it as fault and blame. You know, this is the evolution of science or medicine, right? So now we're at a point where we're going to talk about this over the course of the next hour. Oh, I start out, I'm noticing that my patients aren't getting better. So what can I do to improve the effectiveness of sunscreens? That's where this whole game starts.
Your article emphasizes epidemiological differences between basal cell carcinoma and squamous cell carcinoma. Why is that distinction important?
Way back 40 years ago, there's a study called the Helios study. And what the Helios study did is it looked at the frequency of skin cancer and plotted against the amount of accumulated sun exposure you've had. And what you see is that for squamous cell carcinoma, the least common, you see a dramatic rise. It goes from almost 0 to 1,000 as soon as you hit a certain number of 100,000 hours of exposure. So we conclude, squamous cell carcinoma is a product of total accumulated sun exposure. Now, if you look at basal cells, you see there doesn't seem to be make any difference how much sun you've had. Therefore, the cause is not accumulated sun exposure. You certainly need sun exposure to get a basal cell, but those are two totally different animals to deal with. And the mistake that we continue to make is that we lump them together. Say, they're all the same thing. No, they're not. If being born with a Y chromosome makes me a boy and lack of Y makes you a girl, we're not the same. Right? Fundamentally, there's a profound difference. Okay? That makes sense?
Definitely. The NAMBER study is often cited as definitive evidence for sunscreen efficacy. While it demonstrated benefits for squamous cell carcinoma, it failed to show a significant reduction in basal cell carcinoma incidence. What clinical lessons should dermatologists take from this?
The NAMBER study is very important from a number of different aspects. First, it's a double-blind prospective trial. That's what we should be doing, right? All new treatments should be submitted to this kind of investigation. The fact is, NAMBER study was done by a bunch of derms in Australia who are highly interested in something, never been repeated. It should be repeated all the time. So here's what happened in the NAMBER study and why it's so important. They said, okay, we're going to conduct a double-blind trial. That means nobody knows what the answer is as you go along. They took half the patients and they treated those patients with a sunscreen with a SPF of 16. So that's half. The other half got whatever they use. Okay? So they watched them for 3 years. So they gave them sunscreens for 3 years. And then they watched the results for 10 years. That's unbelievably good information for us. And what they saw is, you could reduce the cancer that's due to the accumulated sun exposure. You can. But it's the little one, the big one, it was useless. Absolutely useless. Well, that's a total shock to all of us, right? We were prescribing sunscreens to our patients, use these, blah, blah, blah. And here comes a little bit of science that says, guess what? Your thinking's completely wrong. And your advice is therefore wrong, which is very hurtful. Well, it's simply true. Right? So this type of study needs to be done much, much more frequently, and it needs to be supported by industry.
Much of skin cancer prevention has focused on ultraviolet radiation. Can you put that in context with respect to the full spectrum of sunlight that reaches the skin?
Absolutely. Very, very important stuff to understand. When you walk out in the sun, you say, oh, okay, I'm outside in the sun, getting sun exposure. What's in the sun? Well, the answer is only 7% of it is ultraviolet light, 43% is visible light, and 50% is infrared. So most of the people who are listening to us today, they're scratching their head saying, what's this infrared stuff? Well, when you go outside and it feels warm, that's infrared, okay?
Yeah.
And that is 50% of the energy of the sun occurs in infrared. It's been totally ignored. So our focus has been on the 7%, that is UVA, UVB, and the rest of it, oh, well, that's the key, isn't it? As soon as you start ignoring something, then some guy like me is going to come along and say, how come we ignore that? So we found out infrared, in fact, is deeply penetrating. It goes right through skin into fat. Nothing else does. Number two, when you expose animals experimentally to infrared, you can exactly duplicate premature aging. So you can make those poor mice look old by just giving them infrared alone. So that means, oh, you and I spend our days treating and focused on people who have chronic sun damage. That's the common feature of cosmetic practices, et cetera, et cetera. So we see chronic sun damage is caused by, yes, UV, but mostly it's caused by infrared. That's the secret. So the others, and the way we learned this is from a guy called Krupman. So we also know antioxidants, those vitamins that are in the cream, what do? They prevent that injury. So they neutralize free radicals, which we'll talk about in a minute, but they do it to protect you. So your natural protection in skin automatically is these vitamins that we use.
Zinc oxide and titanium dioxide are often described as the gold standards for sun protection. Do mineral sunscreens prevent skin cancer beyond their effects on ultraviolet radiation?
I think if you stop with the question I just said, do either zinc or titanium, have they been demonstrated in appropriate studies to reduce the frequency of skin cancer? The answer is absolutely not. The way, and this is very unfortunate, but it's reality, the way the US FDA works is they approve something, they allow everybody to use it, but nobody's ever tested it. So you and I think, oh, it's approved by the US FDA. That means it's safe, and that means that it has efficacy. No, they're way more a political process. So the US FDA had 16 agents that they approved, and they took away approval of 14 of them. They just, they're no longer approved. But they didn't stop you from using them. They just didn't approve them anymore. Well, some of us who have been prescribing and recommending sunscreens all our lives, we're kind of a little bit upset. Here we're recommending treatments that nobody's ever proven. The second is, when you look at zinc and titanium, zinc has a very interesting history. Zinc is the most widely used molecule in the world for skin. So if you're going to pick one molecule of zinc, but guess what? When you micronize it, it's a different molecule. When you do the same thing with titanium, and it turns out when you micronize it, you lose its effectiveness, and it's micronized by being contained in something called nanoparticles. So a nanoparticle means tiny, tiny, tiny. It's so tiny, it enters your skin. You say, well, okay, what does that mean? Nobody has any idea. This is the world, the health of the world, and you're saying you have no idea what it does? Well, they don't, right? Those are not acceptable words, but they are what's here. So at the moment, we say, if you can't get our types of creams, use zinc or titanium. Why? We really don't like them. They are environmentally toxic in the same way that other sunscreens are environmentally toxic. But what choice does the consumer have? So they should choose the best of what's here, but everybody should recognize the profound shortcomings of statements from the US FDA on safety and efficacy, because they don't have any Sad, eh?
Yeah, it is sad.
Now we'll take time for a commercial break. Welcome back.
We know that ultraviolet B radiation is required for vitamin D synthesis in the skin. How do you reconcile the need for UVB with concerns about sun exposure and skin cancer prevention?
What happens in simple terms is that when you read an SPF, you're also reading how much it prevents vitamin D production. So the higher the SPF number, the lower the more resistant your skin is to creating vitamin D. Okay? So as they made sunscreen stronger and stronger, guess what? You produce a profound vitamin deficiency. So that's the first thing to realize. The second is there's a very important piece of research that came out maybe 20 years ago, and they studied what happens. You and I know that in summer, there's lots of vitamin D. What happens in wintertime? So they monitored the blood levels of vitamin D in patients, and they saw that if you live in an area like Edmonton, you produce no vitamin D at all for at least 4 months a year. What does that mean? It means everybody in Edmonton is deficient in vitamin D for 4 months a year. And if you live in Ontario, or Southern Ontario, or you live here in Nova Scotia, same kinds of numbers. Oh, so we literally make no vitamin D at all. So what are we going to do? Oh, we're going to put a sunscreen on it. You've gone from making none to making it impossible to make any. What we have done is we said, oh, okay, you can make people deficient in vitamins by giving them too potent a sunscreen. Okay? Our sunscreens work entirely differently. Right? They don't rely on this sort of blanket, no UVB. Rather, they're vitamin A, which protects from here to here, vitamin C, here to here, vitamin D, here to here. You can design it so that you don't block UVB. And the other is to know when you're out in the sun, what you really do is you destroy the molecules that protect you. That's the way they protect you. They basically commit hara-kiri. They are suicidal. Oh, okay, that reduces the level, right? And when you reduce the level, you reduce the inhibition. So vitamin A, when you go out in the sun, within 2 hours, you've depleted 50% of your vitamin A supply. Isn't that kind of profound? You have to respect the vitamin A because it gave itself to protect you, right? But now there's a recognized state of vitamin A deficiency that's induced by normal sun exposure. Normal. Oh, go out in the sun for a couple of hours at noon. Boom, no vitamin A. Isn't that interesting?
It is. You've emphasized reducing sun-induced damage, but sunlight also has important physiological benefits. Can completely removing sun exposure have unintended consequences?
Absolutely. Not what anybody's recommended. I think there's a profound impact. We're at the beginning of understanding. If you haven't realized that over 90% of the sun you've ignored, you surely don't know a lot about the health benefits, do you? So yes, I think it's absolutely correct. I don't believe that any of us want to completely eliminate sun exposure. That would be completely wrong.
Good. We agree there. You argue that sun-emitted visible light and infrared radiation deserve greater attention. What does the literature show about their effects on skin biology, and how should we distinguish those effects from the safety profile of medical devices that use visible or near-infrared light, such as LED therapy, IPL, low-level light therapy, LLLT, and lasers?
So first, each device has its own specifications, right? So if I'm doing laser, then I'm dealing with this set. If I'm doing a lower level light therapy, a different set of rules. So that's technology, right? There's technical guys that measure this. What's really important is you and me. So where you want to think is say, I'm really reassured by knowing that the procedure is carefully studied, and it is. The treatment is extremely short. So if I'm giving you laser treatments, then literally we talk about microseconds, right? That's 1,000th of a second where I'm giving that little piece of skin an impulse, okay? It destroys it on purpose, right? But it's only a tiny, tiny portion. Most of the skin is sloughed off. So we see the destroyed tissue is gone. So the impact, although we don't know exactly, is not likely to be significant.
How does the free radical model help explain photoaging and carcinogenesis?
Very important stuff. Very complicated, but very important stuff. So what happens is when I go out in the sun, I create injury. So you know that because super white guy, I got a sunburn, okay? Injury, right? So the free radical hypothesis says, how do we understand this? How can we deal with the fact that there's an amount of injury that occurs from sun exposure? So what it does, the free radical theory says, if I'm out in the sun and I receive 1 photon of light, which is this immeasurably small unit of light, what does it do? Well, it in fact creates a chemical reaction inside the cell, okay? Or it might be on the surface of the cell, or it might interact with DNA. But that releases, that chemical injury releases or creates a chemistry which results in the release of a free radical. And a free radical is, boy, am I ever excited. I'm really free. I can attack anything. And the answer is it does. So it attacks its neighbors. If your neighbor's DNA and RNA, now you're saying, oh, I can create genetic change. You surely can. If it's on collagen, I keep damaging collagen by hitting it with all these free radicals. Eventually, the collagen falls apart, and I therefore look old, right? If it's pigmentation, oh, the free radical makes my body create more pigment. Therefore, I have little persistent brown patches on the back of my hand, product of free radical injury. So it's an attempt to deal with our understanding of why injury occurs when we're in the sun.
You place significant emphasis on sun-induced immune suppression. Why is this central to your approach?
This is a very, very important area. So what happened is a real bright guy, an American, by the name of Stralene, did a whole series of experiments. He devoted his whole life to this series of experiments. And what he saw, he did all of his experiments first in mice and then in man. So he saw that when you stick mice or men in light, 40% of people turn off their immune system. Well, isn't that bizarre? Okay. So 6 people out of 10, they just carry on like normal. 4 out of 10, no, they turn off their immune system. And when you turn off your immune system, you now can't see, right? Your immune system's turned off. So, for example, if you and I were going to Hawaii today, and that happened to be the day that you produced a breast cancer cell, okay? Your body's whole immune function is to recognize that that's a cancer and get rid of it. If you have sun-induced immunosuppression, you can't see it. Your body says, no, this breast cancer cell is normal. And because it's normal, I should feed it. And that's what you do, right? So his concept or his description is phenomenally important. So 93% of skin cancers occur in people who have sun-induced immunosuppression. So that says, oh, it's just a little group. It's a little group that's big, but it's a little group. It's a defined group. And half of them become allergic. So that means, oh, 2 years later, I still can't see my breast cancer cell. I don't get over it, right? No, I've created a permanent memory. So to me, this is the key of cancer. The sun-induced immunosuppression is the most important predisposing factor to cancer. Because I'm a skin guy, I'm going to say in skin, right? I happen to believe otherwise. I happen to believe it's more important than that. But that's enough. Skin cancer is half of cancer. So my job is fix skin cancer. That's why you and I are here.
Definitely. Your observations include clinical patients across the full range of skin phototypes, including darker skin tones. How does melanin-mediated photoprotection factor into your prevention model?
First of all, it's clear. If you're Italian, which I assume Fanelli might be,
Yeah, that's right.
probably have a much lower risk than I do because I'm a super white guy. You sure have a much lower risk of sunburn. So we know that melanin is protective. The difference between an Italian and an English guy is the amount of melanin in our skin. So
Yeah.
we say, really, what are we doing suggesting sunscreens in black guys? So here's the hooker. The hooker is what Stralene found, is he said, no, this occurs in all races. So yes, the frequency in a black guy is lower, or an Italian is higher than me for sure, but it isn't very much higher. Okay? So his explanation throws a spanner in my thinking. Okay? But that's why I'm glad you pointed it out for me. So what do? We say, if you're darker, and I don't think Italians, you're not saying an Italian is dark enough. If you're darker than an Italian, then you say, if you have a family history of skin cancer, you should be using a type of photoprotection. Otherwise, you shouldn't. Does that make sense?
Mm-hmm.
Yeah.
Your prevention strategies rely heavily on vitamins. Why take this physiological approach?
So I'll tell you a story. How did all this happen? Well, it all happened when Gord was watching his patients back in Victoria 40 years ago and seeing, oh, they're not getting cancer prevention, right? They're not. Oh, what can I add to their prevention that makes it more effective? So at the time, vitamin A was really big. This is the era when vitamin A was first introduced. I was at the lecture when it was first introduced. I'm that old. I'm really old.
You look good for your age.
Exactly. So we said, oh, okay, what about this vitamin A stuff? So I did a big study in vitamin A and learned a lot. But what I learned was it's very irritating. Oh, so then I went back to the drawing boards and the academic papers, and you see, oh, one of them isn't irritating at all. Oh, I think I'll pick that one. Of course, right? It makes sense, right? It just makes sense. Oh, so now we did vitamin A, retinol palmitate for almost 10 years. And then we said, oh, okay, yeah, the guys are better for sure, and they like their treatments. Can we make it better? Yeah, at that point, vitamin C and vitamin E were really evolving as therapies. Oh, let's add these guys. I wasn't looking for a vitamin to add. I'm looking for molecules that are naturally protective. Oh, and here along comes Burke, is the world's authority on vitamin E. She's saying, Gord, if I use vitamin E, then blah, blah, blah. Another one, Panel, vitamin C. He says, oh, if you use that, we can grow collagen, we can do this, we can do that. So I add them to the creams, right? So now I have vitamin A, vitamin C, and vitamin E, and I am winning. When I have that combination, it's obvious the patients are walking in looking healthy, feeling good, and have a significant reduction in their skin cancer. So I wasn't looking for a vitamin. I was looking for something that would aid me in what I was trying to do. Subsequently, two more were added. Niacinamide. Niacinamide is Damien, an Australian women researcher. She says, hey, if you use vitamin B3, guess what you'll do? You'll reduce the frequency of skin cancer. She's the first one who's done what I'm doing, only she was much more the explorer than I. I just grabbed what she did and I put it in the cream. You see, everybody's better.
Now we'll take time for a commercial break. Welcome back.
So the next one was research with Krupman. So Krupman is a world expert on infrared light. Go to Krupman and we say, can you measure how effective my vitamin creams are in preventing injury from infrared? So he measures it. And he says, Gord, they're pretty good, 80% coverage. And I of course, am saying, I want 100. He says, why don't you add carnosine? Nobody's ever heard of this molecule before. It's been used primarily as an adjuvant therapy in athletes. Well, that doesn't describe skin cancer, does it? So he said, no, we're going to add this. He did. Guess what? 100% blockage of IR. So if you want to block IR, and this is one of the biggest secrets in what I do, you simply add carnosine. Oh, isn't that neat? Well, that's what you learn when you inquire, right?
Yeah, that's great. Well, I learned from you that retinol palmitate is secreted from the sebaceous glands. I thought that was pretty interesting. And so you're basically giving the skin what it already has, right?
Correct.
And retinoids are often recommended for nighttime use due to concerns about photosensitivity. Does this apply to retinol palmitate in your protocol?
Okay. First, retinoids are the mainstay of therapy. Now, you and I, if we want to reverse aging, blah, 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 we're going to use a retinoid. Okay. And there's a whole bunch of them. So this synthetic ones, and you know that as retin-A when it was originally introduced, that's a synthetic molecule. When you use it, it irritates the hell out of your skin. We did prospective trials. We proved that every single patient reacted to retin-A. If you made the strength high enough, they reacted. The ones that are innocent are the ones that occur naturally. Well, nothing's more natural than retinol palmitate. Retinol palmitate is in your bloodstream, it's in your liver, it's the way your body absorbs vitamin A, and then it's in your skin. Okay? You apply it, there are no side effects. And I mean zero. It's unbelievable how little side effects there are. So these are legitimate concerns for sure legitimate. And unless you're using ours, retinol, this irritation from retinol or the photosensitivity of retinol is really low. It isn't as low as retinol palmitate, which is zero. Retinol, say 1%, right? Natural molecules applied to skin don't irritate it. If you put chemical junk on your skin, are you surprised that it gets irritated? Not really, right? Makes sense, right?
Definitely.
So we see when you apply vitamin A to skin, what happens when you put retinol palmitate on? Your body loves it. It eats it. It says, give me more. It raises your skin levels 50 times. That's unbelievable. If you put vitamin C in your skin, raises it 40 times. Vitamin E, 17 times. These are massive increases, okay? But it doesn't bother the skin. It says, oh, this is lunch. I'd like a little second course, right?
Mm-hmm.
Once you get it in there, you say, what happens to it? Vitamin A and E, oh, they last 17 days. They just sit there. If you don't use them, they sit. They're persistent for 17 days. C and B3 are different numbers. We don't need to go through it all. But the idea is once it's there, it persists. Each one has a location. So retinol palmitate is active around the nucleus of the cell. Who cares? But it just technically is there. It's a piece of knowledge. It's important. Vitamin C and vitamin E live in the water phase of the cell. Therefore, they're much more rapid in movement. So the function of vitamin E, in part, is to restore C. Why? Because C is so important. Make sense?
Yeah. So the retinol palmitate that you use, that's the same as what they put in the vitamins that we take, right?
If it says on the label, retinol palmitate, you know it is. That's just a name of a chemical. That is, retinol palmitate is blah, 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 right? If it doesn't say, you don't know. And most commercial products do not use retinol palmitate. Why? We'll come to it in a minute. Because of the EWG. Most are not, but you sure don't know unless you can read a label.
So vitamin A and D share nuclear receptor pathways. Is there concern that topical retinol palmitate could interfere with vitamin D signaling or immune function?
There sure could be, right? Naturally, intellectually, you ask the question because you're saying, could it be? But the truth is, they're synergistic. That is, the presence of one creates a better reaction for the other. That's what's called synergy. If I combine this and this, 1 and 1 makes 2. No, it makes 3. If it makes 3, that's synergy. So there's documented synergy between these molecules, okay? But that doesn't mean you should stop thinking about this, right? You watch your patients, right? Oh, as I treat a person, I need to be aware of it. But has it happened? No, the opposite.
The Environmental Working Group has raised precautionary concerns about topical retinol palmitate, citing animal studies and the broader context of vitamin A overexposure from fortified foods and supplements in North America. How should clinicians interpret these findings, and how does topical use differ from systemic vitamin A exposure both within and outside North America?
So what happens is every year the EWG publishes a list of what it calls dangerous ingredients. And the top most dangerous ingredient in the whole world, according to EWG, is retinol palmitate. They say, hold it, this doesn't make any sense. How can a molecule that's naturally in your skin be that dangerous? So there have been at least 5 reviews of retinol palmitate, every one of which has concluded, oh, not only is it safe, there's no evidence of injury, none, but it probably gives you this photoprotection that might be really important. So I've written the EWG, medical authors have written the EWG, we publish articles. They don't change. They refuse to learn. Well, if you refuse to learn, I stop listening to you. But if you refuse to listen to the more authoritative voices who you've presented the problem, here's the research we've done, they won't listen. They won't change. Well, as soon as you're like that, you lost me. I'm gone. I have nothing to do with you. So I appreciate that there is this concern about fortified foods, etc. It comes from the EWG. I won't even read it. Why would I read something from a person that I don't respect? I disrespect them. I almost hate them.
I'm
Because
sure you do.
is injured people. By warning people not to use a molecule that I'm saying is perfectly safe, and here's the literature, blah, 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 you're preventing people from using things that are good for them. Well, grow up.
Well, we had 2 different trains of thought here. Okay.
No, you can see I'm not happy with these guys.
I know you're not happy with them.
No,
Well, thanks for telling me your
I
viewpoint.
apologize for spilling that emotion. But the truth is, you can't do that.
Okay, let's talk about L-carnosine. It's a naturally occurring dipeptide found predominantly in animal tissues. Its dietary origin raises questions about applicability for vegetarians and vegans. Well, you sort of discussed what prompted you to put it into your prevention strategy, but can you address if it's vegan or vegetarian friendly?
Absolutely, it's vegetarian friendly. So, yes, there are concerns that people have. This molecule is new. So to my knowledge, I'm the only guy who says, oh, this is the one that protects you from infrared. There must be other people that say that, right? But I'm not aware of it. I'm the only guy that uses it that way. Oh, so then about 2 years ago, Krupman, same guy, wrote another article. And he said, rather than using minute strengths, let's increase the strength. So he did by about 1,000 times. And guess what? When he did, he showed that you can prevent the accumulation of injury in skin that is characteristic of aging. Oh, so today, if you go on the net or whatever, these guys, and you type in carnosine, you're going to get thousands of hits because it's the big new molecule in cosmetics. Now, should it be? It sure should. This preventing aging is profoundly important. So what we do is we just put it in our creams. Oh, so for me, phone the formulator, can we increase the strength from this to this? Sure. Oh, way you go. So it's in it, okay? But does the world know? Nope. That's why you're here. Help the world know. Thank you.
Okay, your product is pharmaceutical grade and environmentally friendly. Are the vitamins used in your formulations made in the laboratory, and how are they formulated?
Yes, they're made in the lab, and they're made this way. We say, oh, the form of vitamin C that the body likes the most is called the L form. So you remember when you were in chemistry, and you may or may not love chemistry, but you remember, oh, there's a dextro and a levo, so there's an L and a D. So it says, oh, The one that your body likes is L-ascorbic acid. Therefore, the one we formulate with is L-ascorbic acid. Vitamin E, there's 16 forms of vitamin E in your diet, but there's only one that works. That's the alpha tocopherol. We know that from Burke, this lady who is very smart. So Burke says, oh no, let's use this one. Well, that's the only one we use. We don't put the other 15 in. No, we separate them. So you go to your formulator and you say, I want you to formulate with retinol palmitate, vitamin C, vitamin E, vitamin D, blah, blah, blah. His job, what he's an expert at, and I'm not, is, oh, when you put all these together, what happens? How do you create something that isn't crazy goop that you'd hate using? So that's what a formulator does. I say, I want this and this and this, and he says, oh, we're going to do it this way. And away they go.
Are there situations where retinol palmitate in combination with your other vitamin products should be paused, such as cosmetic procedures?
Right. The answer is the opposite. So my experience, I did lasers, I did some of these other procedures. And what we did is we pre-treated people for 2 to 3 weeks with the creams and said, oh, we're going to increase your body stores. Because when I injure you, I need you to be able to repair fast, right? So rather than run away, no, we go bang. And does it work? Yes. They get better much faster. They're much more comfortable. If you listen to patients, they'll tell you, oh, I like this stuff. It's really helped. So that's where we come from.
Okay. Some patients report improved sun tolerance with oral antioxidants such as astaxanthin. How do you view these agents in the context of skin cancer prevention?
I thank you very much for teaching me about this molecule. So I looked it up. It is potentially profoundly beneficial. So let's go where we really are. We, at this moment, you and I are saying to the world, we can prevent skin cancer. That's brand new. So agents like this, which are in relative terms, relatively unknown, blah, 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 right? They don't get a place until after 10 or 20 years, the knowledge is sufficient where you're picking it, right? I certainly read I read a review article or two about this. I thought, boy, we're going to do our clinical trials. And if we see they're not 100%, guess what? I'm going to add something to make them 100, aren't I? Because I'm that stubborn, I want 100. I don't want 98. I want 100. So I sure am aware of this molecule because you got me to, and I'm very pleased you did. I'm certain that many, many of these molecules will become important, right? And some of the world's authority, the guy I keep quoting is Krupman. Krupman just wrote an article, 2 years ago on the role of oral vitamins in preventing skin cancer. Well, it turns out it isn't anywhere near as good. And it's simple. You can't possibly raise your skin vitamin A by eating it. Not possible. You'll kill yourself first.
Mm-hmm.
So it turns out applying it is simply the most efficient method known in man, but subject to change over time, of course. But that's why we do what we do. We put in a cream, apply it, and we see there isn't a limit so far. But with this, I am sure that we won't be 100%. I'm sure of it. 93 is the figure I would use for different reasons. But then you're going to start formulating with these molecules. That makes sense?
Yeah.
Now we'll take time for a commercial break. Welcome back.
Many naturally pigmented foods are thought to provide some degree of sun protection. What are your thoughts on diets rich in colorful foods and their role in reducing sun damage?
Again, this is in the last 5 years, maybe 8 years. I've seen a whole number of articles like this. So that means a single researcher has got involved enough that he does a trial or writes this or blah, blah. So it's sure the future. It sure is. The future isn't here because we're still way back here. We're, come on, let's, in I have been going to the American Academy of Derm meetings since 1979. At no point, except when I get up and talk, does anybody talk about preventing skin cancer. It's unheard of. So first we got to get through this. We got to get the public to see, no, it's feasible, reasonable, easy, and rational. Let's do it. Then you start looking at what's the effect. But I am certain that there's value in it.
Oh, that's good to hear.
Oh, yeah. For one, they're carotenoids. The color is produced by a carotenoid. That's a character, a group of chemicals. Guess what? They're all the precursors of vitamin A.
Yeah. And I'm big on carotenoids.
Absolutely. So you might prefer to eat it, but at the moment, I can't tell you how much green pepper you have to eat to equal mine. Probably pretty high, but hey, absolutely huge area of medical research.
Some have suggested that changes in the global environment, such as ozone depletion or climate change, may be responsible for rising rates of non-melanoma skin cancer. Can we assume that ozone reduction or the mitigation of global warming is the primary cause of this increase?
Absolutely not. So you and I discussed the fact that when you look at the common form of skin cancer, it isn't due to chronic sun exposure, right? We said, squamous cell carcinoma is. It's accumulated sun exposure. So there's other stuff in humans that's more important. And the other stuff is Stralene. Stralene says, no, you get skin cancer because you've inherited an abnormality in the way you react to the sun. That's the reason. That makes sense? So we all recognize ozone depletion as occurring in the last 15, 20 years. We can identify where it occurs, and you can measure what effect it has, okay? It ain't raising cancer rates that are identifiable. I'm sure they're there, but we can't identify them yet. Later on, we will. Global warming, we all believe that global warming is a product of human activity. We're idiots. I can't believe what we allow. We'd rather suffer the side effects. So yes, we're in the middle of global warming, and you and I see it every day. Are we going to change it? I don't think so.
Given the slow natural history of non-melanoma skin cancer, over what time frame did you begin to observe meaningful reductions in new lesions?
It's a very interesting question because you're designing a research study, right? You're saying, okay, we're going to follow these guys on treatment. And what we're going to use is the index, is the frequency of basal cell. Okay, that's the key. What happens if it occurs within a week of starting therapy? Or if it occurs within 3 months? What do you say? So you have to make a decision in your own mind. You say, I'll go for 3 months. So any cancer that appears in the first 3 months, we call a previous cancer that's being made apparent. Okay? Is it correct? No, you could sit there and argue with me for hours. It wouldn't do any good, but you could, right? Reasonably, you could say maybe it should be 6 months. We don't have that level of knowledge. We don't. So, yeah, but your question is correct.
What did you see in your patients?
That's a huge one. And it's really, really important. So you're treating people every day, right? And they come see you every 6 weeks, roughly. And what do they say? They say, Gord, my skin looks so good. My wife says my brown spots are going away. The patients were enamored, and I mean enamored, with the benefits they saw in the quality of their skin. Yep, over time, they would see a reduction in the frequency of skin cancer, but that's very hard for you as a person to detect, okay? So what they said to me is, Gord, look at this. Look at my colors evening. My skin feels really healthy. That's what we saw.
Yeah, I read your testimonials. I saw a lot of positive reviews on it.
Yes, it was fabulous. So that got me really excited about another area that we're not going to discuss much, but is your area. Improved appearance. Unbelievable. Unbelievable.
Okay, so now we're going to start talking about your product. You stated that your product lasts 100 days and it's only a 30 ml size. How is that possible?
2 reasons. First, you say, how do you deliver the treatment? The answer is an airless pump. So an airless pump prevents any contamination that normally occurs when you reach into a jar. So when you manufacture the airless pump, you say to the guy, oh, I want to deliver 1% per day. So he sets the amount that comes out in a single pump as 1% a day. And it is. So literally, so that's the first thing to know is I set that. Okay. The second thing to know is if you leave skin wet, what happens is it forms this little thin layer that spreads it. So you can make a cream last 5 times longer by putting it on wet skin.
Great. You indicate that your vitamin A formulations are considered safe for use during pregnancy. How should this be understood?
This is very, very important stuff. Okay, very. So when Accutane first came out, I wouldn't prescribe it to women until it was proven safe because we know it's toxic. So there's an environment that says any vitamin A molecule is potentially toxic. So what guys have done, and I'm literally reading a study in which they took young women, they gave them topical retinol palmitate every day, and then they measured their bloodstream. So they took a sample of blood and they said, does anything go from the epidermis and dermis into the bloodstream? The answer is 0. So it's consumed within the skin. Therefore, it's entirely safe, right?
Yeah.
That's why I say that. I don't believe it will take a long time for women to be confident using it. But the medical facts are absolutely clear. There have been numbers of studies like this. That's just the clearest one. So they did an interesting thing at the end of the study. They gave them oral therapy just to prove that their system worked. Yeah, they spiked their levels, all right. So topical therapy, no absorption whatsoever. My advice is safe in pregnancy and safe in children.
You emphasize that your approach is not intended to replace all other sun protection. Do you recommend that people still use a conventional sunscreen if they anticipate prolonged outdoor exposure?
When I wrote this article, right, I hadn't done the next article, which you and I will review shortly, which is the toxicity of sunscreens. I no longer believe that sunscreens have any value whatsoever, and I think they're environmentally toxic. So my honest suggestion is, oh, you should use our cream twice a day. Remember we said, oh, the sun destroys vitamin A? You're reloading vitamin A, right? So yes, the statement I made, I would now retract it. I would say the
Okay.
dangers of sunscreen.
Yeah, it was an
are
old
too
video
high.
that I saw that went in. What are the limitations of your work and what research is still needed?
It's a very good question. So what happens is this is an open label study. An open label study says, gee, George, I know you're 86. Would you undertake a study with me? And George says, great. Oh, good. Put this cream on and we'll measure your frequency of skin cancer. Well, he got sick when he was going to come and follow up, right? Or he went to Hawaii or he did something else, right? So these are normal people. I don't pay them. I even charged them for the cream because I didn't have any financial support whatsoever. That's not the proper way to conduct a study. The proper way is called double-blind prospective trial, which you should now perform, except I don't have that kind of money. But 200 patients, half on treatment, half not, for 3 years, followed by 7 years of observation. Well, you can guess I'm now, what, 78? So if I was doing that one, that's now I got to be 88 before I'm finished. That's what needs to happen. Oh, okay, Gort, you've said it reduces the frequency by 50%. What does that mean? Oh, it means exactly this. We don't know exactly what that means. So that's one of our big limitations in what we've done. The same thing, there's a massive field of the cosmetic improvement of patients on treatment. I've studied it, I've written it, but it isn't known. Should be the same, right? Double-blind prospective trial of 200 patients over 3 years of treatment and 7 years of whatever. You understand the idea. So that formality must occur so that IDA can say, you know what? He proved that. And when it's proven, you feel confident. If it isn't proven, it's a great idea. Limitations of inexactitude. Well, I knew that when I started. But now, no, now it'll be done. It won't be me. I'm too old. But other guys are going to come along and say, oh, I think maybe you're not telling the truth. Let's test it. Well, that's exactly what you want them to say. Make sense?
Yeah. Okay, we're getting near the end, so I have to say this interview reflects the clinical experience and interventions of Dr. Telford. It is intended to stimulate scientific discussion and encourage further investigation into physiological-based prevention strategies for non-melanoma skin cancer. Disclosure. Affiliation. Dr. Telford is the formulator of the commercially available pharmaceutical-grade topical vitamin preparation, which is safe for the environment and all skin types and is vegan-friendly. For further information, I'll put the link below in the description section. This interview focuses on clinical reasoning, mechanistic evidence, and published literature rather than product-specific claims. I've added links which include other related information in the description section. You can retail or wholesale these products on this website, www.cloudvitamincream.com. And thank you so much, Dr. Telford, for being here today. I really enjoyed talking to you and learning from you. I learned such a great deal from you today, and I was researching you.
I'm so pleased, Kit. That's really nice. So the important message is skin cancer, which is the most common cancer of all, is now preventable. That's what I want the world to know.
And that's an important message.
Absolutely. Thank you for your interest.
Okay, thank you.
Thank you for tuning in to Where Science Meets Self-Care with Ida Fanelli. Ida bridges clinical science with holistic wisdom, guiding you toward radiant skin, balanced energy, and lasting well-being. Don't forget to subscribe, share the show, and join us next time for more inspiration and practical tools to help you live beautifully inside and out. To connect with Ida, visit linktree/Ida Fanelli. Until then, take good care of yourself. And remember, self-care is where science and soul meet.